Good afternoon, everyone. So I've changed some topic has been changed for this. My topic now for because we thought that retinal vein occlusions is very similar, or not I can say the similar, but very similar to what diabetic retinopathy is, and once we are discussing not the conditions which are other than diabetic retinopathy, so better I changed my topic to vascular anomalies and surgery. So some of the vascular anomalies that we generally come across in our OPD is either the telangiectasias or the vascular tumors. So telangiectasias include the Coates disease, the Leber's-Millery aneurysms, the retinal arterial macroaneurysms, the congenital retinal macrovessels, and IRWAN. And vascular tumors, as Dr. Manish has also shown some very good videos about them, the capillary hemangiomas, the cavernous hemangioma of the retina, the racemes hemangioma, and the vasoproliferative tumors. So what is Coates disease? Generally we see in young males unilateral, there was light bulb telangiectasias with yellow subretinal exudation, sausage-like dilated vessels in peripheral non-perfusion. I think once you see a patient of Coates disease, you're not never going to misdiagnose this later on. So Leber's-Millery aneurysm is just a part of Coates disease spectrum, and the aneurysmal dilations are seen between the macula and the equator, and there are no peripheral lesions. So now this is just a part of Coates disease spectrum. Earlier it was considered to be a separate entity, but now we include it in the Coates disease itself. Then congenital retinal macrovessels are the aberrant retinal vessels which cross the macula and the horizontal raphe, and as you see in these eyes, generally what the retinal vessels obey the horizontal central line and they don't cross the hemispheres. But sometimes these kind of retinal macrovessels can be present, and they may cause edema also in these types. And this is a one particular case I saw where there's a double crossing, the superior vessel crossing down and the inferior vessel crossing up. So, and generally there's an absence of fovea avascular zone if the congenital retinal macrovessel is passing very close to the fovea. And IRWAN is the idiopathic retinitis vasculitis aneurysm neuroretinitis, and it is characterized by the presence of arterial knots or multiple arterial macroaneurysms. If you see, if I have a, okay, if you see here, let's take the pointer. Here, some of these, you see, these are the arterial knots which are present. Here another one. So these are multiple arterial knots which characterize this IRWAN disease, and there's also retinal telangiectasia. Hemangioblastomas, I think Manish has covered a lot, which may be present sporadic, or they can be associated with von Hippel's-Lindau disease. They are orange-red vascular tumors. They have this dilated feeder vessels. The cavernous hemangioma of the retina, sometimes appears similar to the capillary hemangiomas, but more of these hemangiomas occur in clusters. They appear in group of 5, 6, like the bunch of grapes which is hanging over there, and these may or may not have feeder vessels. Then cavernous hemangioma of the choroid is another vascular entity which needs to be differentiated. In this choroidal cavernous hemangioma or the choroidal hemangioma, which you know it more popularly, is circumscribed or diffuse and is associated with Sturge-Weber syndrome, round to pink oval lesions, and fuzzy margins. The racemes hemangioma, direct AV communications with massively dilated vessels, and lastly the vasoproliferative tumors, the dome-shaped or globular angioma-like lesions, yellow, pink, or red. Subretinal exudation in periphery and epiretinal membrane or traction is more common, and there are no dilated feeder vessels in vasoproliferative tumors. So what is the indications of treatment in these? So all the vision-threatening complications, namely macular edema, retinal detachment, vitreous hemorrhage, submacular hemorrhage, epiretinal membrane, massive lipid exudation, neovascularization, or amblyopia. And the various modalities of treatment at various stages of this disease, laser can be used in cryopexy, the intravitreal injections have been used, external beam radiotherapy, brachytherapy, transpupillary thermotherapy, the PDT, or surgery. So we are generally here going to discuss surgery in these vascular anomalies. So some situations where surgery is indicated See, this is a patient of Coats disease with the retina is lying just behind the lens, and was a 5 years old male. The best corrected vision was PL plus, and the patient had leukocoria for the past 6 months. So in these type of situations, we have to settle the retina. Just the visual prognosis is very bad, but just to prevent the patient for going into the new vascular glaucoma, sometimes we have to do the surgery here, and I'll just show you a surgical technique which I generally do. Now, yes, now it's coming. So what I generally do is I use a IV 26 gauge IV catheter in these type of situations. I insert it bevel down as far away from limbus as possible, then examine the tip in the subretinal space. And once I am sure that the tip is in subretinal space, I advance only the plastic cannula inside, remove the metallic stillet, and you can see this fluid coming out. You can even connect this to your extrusion pump, and you can control the speed of your absorption of fluid. You can make it faster or slower. You can make it faster if there's a lot of fluid, and if you can make it slower when the fluid goes down, so that the retina does not get incarcerated into this tumor. And this was the patient of Coats disease that that I was talking of, and we did the same in this eye. And as I told you, in exudative detachments like Coats disease, it helps to flatten the retina without creating any retinotomies. And the faster creates space, and the slower prevents incarceration. Once you have enough space, you can inject triamcinolone, or if you want to carry on, do a vitrectomy as I did in this eye. While you are doing vitrectomy, you can even leave the cannula inside, because it's a plastic and does not hurt. It's not sharp, so it does not hurt or cause injury to the retina. So in this case, I left the cannula inside. We proceeded with the vitrectomy. We allowed the retina to settle down completely, and we did cryo to the periphery, and this is 2 months post-op. Patient did regain a little bit of vision in this eye, but the main aim in these eyes are generally to prevent them from going to neovascular glaucoma. And this is one more patient similar. You see, I've put the IV AC just to make sure that there's no sudden hypotony or bleeding while you are inserting this cannula. So you make sure that the pressure remains high. So I'm again, as you see, the fluid is coming out, and once you have space, you can either, if you want to proceed with vitrectomy, you can proceed with vitrectomy, or if you want to just give an intravitreal steroids, you have enough space to give intravitreal steroids. So this is another case of a 17 years male. Best corrected vision was 6/18, and he was diagnosed to have these Leber's miliary aneurysms, the aneurysms which were present only between the macula and the equator, and there was recurrent exudation in this patient. So when he presented to us, his best corrected vision was 6/9. 6/18 we gave intravitreal Ozurdex, and the vision improved to 6/9. We had given multiple injections after that. He came in 2018, then in 2021, after 10 injections, in 3 years' time, his best corrected vision has gone down to 6/60, and the exudates have migrated into the fovea, and the steroids, though they temporarily relieved the edema, but the vision now was going down, and we thought we'll just try vitrectomy in these eyes. In this eye, we did a vitrectomy. We induced the PVD. We have to take care. This vitreous is very tightly adherent in the areas where these aneurysms are, so you have to take care you don't cause any bleeding over there. And we just did ILM peeling in this eye. We thought of that same rationale, that if we remove the ILM, we may cause a better absorption of these subretinal exudates. So we did the ILM peeling, vitrectomy followed by the ILM peeling, and then we did do a focal laser over these aneurysms. In this patient, we did a very wide, actually, ILM peeling. So focal laser over these aneurysms. The So this was 6 weeks post-op. The patient's vision improved to 6 by 24. The exudation has started going down, and this is subsequent follow-up. The patient's vision had improved to 6 by 9, and the exudates have totally disappeared. Now, this patient is following me up now. I think it's more than 9 to 10 months, and there is no recurrence after the surgery. This was another case that we did Leber's mealy aneurysms with the branch retinal vein occlusion, and also had similar response. This is a patient of Irwan. This also patient had a recurrent macular edema. He also had now started slight amount of hemorrhages were also started appearing. So you see in these knots, the arterial knots. This means Irwan. So again, the similar procedure we adopted. We did a vitrectomy, we did ILM peeling, and then we did focal laser to these knots, arterial knots. Although I don't think whether they helped or not, but we just gave it, and we also did. The literature also says that you give a 360-degree peripheral scatter laser photocoagulation also in these eyes. So we did that, and ultimately this patient also following up now without any recurrences. So for macroaneurysms, they sometimes present with submacular hemorrhages, and yeah. So in this patient, for these patients, generally nowadays we do vitrectomy with subretinal injection of TPA. So now this vitrectomy is done, PVD is induced. The differences in vitrectomy in these eyes, I generally prefer to use a ICG dye in these patients because of the better contrast that it gives. Because the subretinal hemorrhage that is present sometimes does not, the brilliant blue dye does not give a good contrast. So I did a ILM peeling, then removed the sub-ILM blood which was present, and then using a 40 gauge micro cannula, we have injected subretinal TPA and created a bleb covering up to the area of the arcades. This was followed by injection of SF6 gas and sutureless closure. So post-operatively, again this is 2 weeks post-op, the patient's vision had improved to 6 by 24. 4 weeks post-op, the patient's vision had improved to 6 by 12. So if I have time, can I show, because I think we have a lot of time in this symposium.
So can you show that video of your retinectomy? And
so I'll just show a few videos of hemangiomas. I think it will be interesting. So this is a 28 years male, sudden decrease of vision, right eye. Left eye was thiacical, no significant systemic family history. So he presented with these multiple angiomas, and he was advised surgery at this stage, but he was not ready for it. However, he came a week later, and you can see is 1 week earlier there was no PVR. Week later, he had a severe PVR in this eye. So this patient I had done in 2008, quite a long time ago, and I searched literature that time, but I could not find any thing. So at that time, what we did was, again we thought that we'll do the excision of these tumors. So we removed almost 7 to 8 tumors. 7 to 8 tumors from this eye. The patients, we did tackle the PVR first because we are planning to do large amounts of retinectomy. So we tackle the PVR first, because if we do a retinectomy beforehand, we'll even create larger retinectomies. We wanted to minimize the size of the retinectomies. So this was a 20 gauge surgery at that time. I am using a vertical scissor to go around these tumors and cut them and excise them and remove them in toto. So at that time, I did not have any access to any previous studies. So I thought because this was the only eye of the patient, the other eye was already thiacical. So we removed all these 7 tumors in toto, and then we did the fluid gas exchange, the oil, uh, and other things. And the patient's vision over a period of time improved to 20 by 200, and we were able to remove silicone oil quite after some time. But this then patient gave me enough confidence to further treat these eyes with excision. So this was another patient, the retinal cavernous hemangiomas, and he had a epiretinal membrane development, and this was the case what Dr. Manisha was talking about. So we did. Sure, sure, sir. Sure, sir. I think it's getting stuck again and again. I think we have a lot of time. This session, we have a lot of time. So the difference, what I told you was the hemangiomas, the retinal cavernous hemangioma and the capillary hemangioma. The cavernous hemangioma usually occurs in clusters. The ERM was removed as we were trying to remove using the PVD, and we trimmed the vitreous all along this area. When we were trying to peel off this thick fibrous membrane which was present over these tumors, there was oozing of blood from these tumors. So I thought I'll just stop here and try. And then I did 100% deep diathermy burns around this area, the whole of this area, and then using the cutter itself you can uh, remove all these tumors. We did a ILM peeling just to make sure that there is no recurrence of ERM and all the tractional components are taken care of. And you see I did a retinectomy in this eye, the whole tumor. Just with the cutter itself we were able to remove this tumor in toto. So it was just a retinectomy that we have done. The choroid was not touched, and, and then after this we did a fluid air exchange, and we just used gas in this eye as a tamponade. The retina was attached otherwise. We did endolaser around this area, and also 360-degree a prophylactic laser barrage was done to the periphery of the retina. And just the gas tamponade. And 2 months post-operative, the retina was well attached. The patient's vision had improved from 636 to 624, but he also had developed a little bit of cataract in this eye. So again, 4 months post-op, the similar thing was there. The exudation has decreased. So with this, I end this talk here.